This is the University of Otago.
Thanks for coming along. It's great to have so many people from such diverse parts of the university here. My name's MPhil. I work in the Centre for International Health, and it's a great privilege to have Fulton Shannon here from Liberia. Fulton was trained with a Bachelor's of Science, and he has 2 master's qualifications. He did his master's degree in Ghana, at the University of Ghana, and I've seen his thesis, which was a case control study of the risk factors for acquiring Ebola disease in healthcare workers, and it had some very interesting results suggesting that there was critical components of healthcare that were lacking in the facilities after patients, before and after patients were admitted. He's now coordinator of the Strategic Information Analytics Group in the Ministry of Health Liberia, which is slightly different from how I advertised it in the flyer, because we were in a rush and I couldn't remember all those words at once. So I'd just like to welcome Fulton. It's a fantastic privilege for us to have someone from Liberia, from the wonderful country of Liberia, and who's experienced many different challenges that many of us will never have to face in your life, and he's going to tell us about one of them and I've asked him to give you a feeling for the country of Liberia as well as the Ebola situation and what we look forward to in the future. So please welcome Fulton to the stage.
Good afternoon. Thank you very much, Prof. Hill. Well, I think the introduction was quite detailed, and just to repeat what was said, I'm Fulton Shannon. I work with the Ministry of Health in Liberia. So the Strategic Information Analytics Initiative is one of our new projects that enable us to bring together all of our subsystems under our overarching health information system at the Ministry of Health. So it's fairly new. We have barely started some of the detailed workings, but we actually will get there as we go along. So Liberia is a very small country, probably may go into New Zealand maybe once or twice. And we cover a land space of about 600 kilometers long and 200 kilometers wide. We have a population of 4.5 million, and this is actually a projected population based on our growth rate of 2.1. The last time we had a census in Liberia was in 2008. So we're supposed to do that every 10 years. So next year, we're now preparing for another census in next year. English is the official language in Liberia, and we have 16 indigenous groups or tribes or different languages in Liberia that in addition to English, I spoken. Unfortunately, I cannot speak any of them, though. The largest city in Liberia is Monrovia, and Monrovia is our capital city. So we divided into 15 sub-political divisions we refer to as counties. And within those counties, we have the health ministry for oversight and supervision divided those sub-counties into 90 health districts. So this is a map of Liberia, and we are bordered on the west by Sierra Leone. Just for the sake of information, there's some natural disaster happening now in Sierra Leone, and we hope that we can all keep them in our prayers. In the north by Guinea, the east by the Ivory Coast, and we have the Atlantic Ocean just by the south. So I thought to just give you a feel of the Liberian story, just so we understand where this country has, how this country has evolved over the years. So we actually was founded in 1847 by a group of free slaves from the United States under the banner American Colonization Society. And we gained independence. People won't agree with that, but we actually gained independence in 1847. And the first major political turmoil we experienced in Liberia was in 1980 when there was a military coup d'etat. And this was actually based on the fact that the indigenous people thought the so-called American Liberians were enjoying everything that the country had in whether it's the best schools, best health care, and they were lagging behind. So they thought the best way in their mind at the time was to take power by force. So they took power in 1980 on the 12th of April. And they ruled up until 1989. Within that group of people, there was another form of disagreement in terms of even though the indigenous were ruling, but again, a segment of them did not feel to be part of the enjoyment. So Charles Taylor led a revolution in 1989, and that civil war went up until 1997. There was an election. He won the election, landslide, but just after 2 years, there was another outbreak of a civil war, which ran until 2003 when Taylor left Liberia in August. And then in October, on the 11th, 2005, we elected the first female president in Africa ever, and did that also in 2011. So her term actually ends this year. We have an election in October, and hopefully we can elect a better leader. And then came the Ebola outbreak in March of 2014. So this is a slight view of the city, Monrovia, and this is West Point. If some of us has been following the outbreak development, West Point is actually the largest slum community in Monrovia, and during the outbreak, this entire community had to be quarantined because there was some huge spread of EVD among the population. We also have some very beautiful beaches, and the picture right here is the Libasa Eco Lodge that we usually go for relaxation, and tourists are invited to come over. This one shows the locals doing some celebration on the beach. We have some wildlife in Liberia. The chips are available. We have natural reserves, and this is the highest form of the highest landform in Liberia, the Nimba Mountain, very well known to concession companies that involved with minings and all that. Liberia play host to the Firestone rubber plantation, one of the largest rubber plantations in the world, over 100,000 acres. And the major source of feeding with a lot of our families is through subsistence farming, and our staple food is rice. So you see here in this picture, they're planting rice, and also in the next one, they harvested after some time. And then the sad pictures of the civil war in Liberia and the Ebola outbreak. So as we all may know, Ebola is a zoonotic disease, though largely the natural reservoir of this virus is unknown, but bats, specifically fruit bats, have been implicated as a reservoir and a host. Over the period of time, there has been spillover events of Ebola transmission from animals to humans and subsequently between humans to humans. It's very fatal, with a case fatality rate of between 45 to 90%. And it was first detected in 1976 in southern Sudan and northern Zaire, which is now called the DRC, Democratic Republic of Congo. In an acute circumstance, an onset of signs and symptoms is between 8 to 10 days, but generally it stretches between 2 to 21 days. And some of the common signs and symptoms include fever, muscle pain, and after 5 days there are signs of gastrointestinal symptoms, headaches, conjunctivitis, and studies have shown in about 18% of those infected with Ebola, we have hemorrhagic symptoms. Now, in a country like Liberia, where malaria, typhoid, and other diseases are endemic, detecting Ebola is kind of difficult because some of the signs and symptoms, early signs and symptoms that manifest in an infected patient resembles that of malaria, for example, which may most likely lead to differential diagnosis in some cases. So when infected, the virus tends to present itself in our body fluids and excreta in someone who's infected, and there are opportunities for human transmission through direct contact with a person who's sick or a person who has died from Ebola, indirect contact with cooking utensils, eating utensils, medical waste, like used needles and other medical equipment that may have been used on an infected person. There is limited information on domestic animals like dogs and cats being hosts or being susceptible to Ebola infection. There's still some studies ongoing to understand whether that is actually true. A person is only infectious if he or she starts to show symptoms. So if within the incubation period 2 to 21 days, someone may be infected but may not be able to transmit because they, at that point in time, are not showing signs and symptoms. Until that onset, you are not contagious. And there has been some studies to understand whether one can get infected with through inhalation of aerosols, but that hasn't really been established up to now. During the outbreak, there were 3 main methods used to diagnose Ebola in Liberia: the PCR, real time, which requires a collection of about 4 ml of whole blood from a suspected patient and oral swab of a post-mortem victim. And there was also the ELISA that we also collected whole blood, but this time in a different medium because you require to use the serum for testing. And then there was the rapid diagnostic test, RDT, that was also used in the field. Now, when a sample is collected by the SOP states that within 24 hours, 72 hours max, because if you look at the topography of Liberia and the challenges with bad roads and inaccessible communities, we thought to step that up to 72 hours so that we gave some leverage in time for transport for transportation of these samples for testing. And once the specimen reaches a point of test, it's between 8 to 24 hours to have the lab results after testing. So when a case is detected or a case is suspected, it requires that the health worker who detects that case collect a sample as described in the previous slide, and that person in a hotspot community at that point in time, because we wanted to actually manage transmission, we set up what we called at the time community care centers. Those were usually makeshift centers, either in a room, a makeshift room in a health facility or a school, depending on which infrastructure was available at that point in time that we could use quickly. So that person gets moved to a CCC if it's a hot spot community, or the person will get actually transported to an Ebola treatment unit, which we term as ETU. The primary mode of transport was the use of ambulances, but there are cases where ambulance at a point in time may not be available. Some other vehicles were used for transport. As we all know, there is no known cure for Ebola. So a case of Ebola will actually go through some supportive care, IV fluid resuscitation, electrolyte replication, oxygenation. Those are the clinical management that I personally won't like to go into because I'm not a clinician. But these are just some of the few therapy that were used to manage Ebola patients during the outbreak. So within the ETU, we also established what we call a probable and suspected war. So you wouldn't just come to an ETU and get moved to where confirmed cases were. So because after some time, even if your test comes positive, we run it for another time to make sure that you're actually a true positive before you get moved to the actual treatment unit or treatment ward within the ETU. So this is a picture showing a patient who's bedridden, being taken into an ETU. The ELWA2, one of the most famous ETUs during the outbreak. This is another picture of it. And in one of our counties, bombing, this is a picture of one of our community care centers. And you see these people here, they were all suspected cases of EVD, and their pictures are in there. So the Ebola outbreak in West Africa was actually the largest ever since the 1970s when it was firstly detected. Statistics show that there were over 28,000 infections and over 11,000 deaths spread across 10 countries and 3 continents. And on the 8th of August in 2014, the WHO declared the outbreak public health emergency of international concern. So this map actually shows a history of Ebola. The ones in red show those sporadic outbreaks that occurred before 2014 in the Congo, Gabon, Southern Sudan, Uganda. And then the one on the right, at the left, actually shows the outbreak in Liberia as of the 4th of August. About 9 of our 15 counties are already reported cases of Ebola by August that time. And this is actually a map of Guinea, Sierra Leone, and Liberia, but this map shows the epicenter of the outbreak, the origin of the outbreak, where the outbreak originated, actually in a place called Gegedu in Guinea. And our index case went for a funeral in Gegedu, because in Liberia, Sierra Leone, and Guinea, especially within this region, they speak a common language or common indigenous language of Kisi. So here was this person came for a funeral, and in Africa we have our own different practices, funeral rites when a person dies. So that individual, actually a female, got infected here and got in a public transport and drove all the way down here to Monrovia. And along the way there were some transmission occurring. So basically we had one big wave of the outbreak in Liberia and 2 smaller clusters between 2014 to 2016. The larger one was in March, which was the first one. After almost a year, actually a year from March 2014, on the 9th of May 2015, WHO declared Liberia Ebola free. But then there was still, we had something we called heightened surveillance. So we were still on the alert because there were still transmissions in Guinea and Sierra Leone. So because our borders, about 80% of our borders are porous, there's no control over movement, and people will walk in at any point in time. So there was heightened surveillance. So on, it was around the 29th of June, I actually come back to do one of my outputs from Ghana. I was in school. I actually come back to do one of my outputs, surveillance system data analysis, when this outbreak was reported. And I was actually one of those investigating this one in June, this small cluster of 6 cases, which occurred in a smaller county called Margibi, and then later spilled over, having 3 cases in Montserrado. There was a tail one in November, which we had like 3 cases that actually occurred in a community called Dupont Road in Monrovia, Montserrado. So on the overall, we had over 10,600 cases of EVD in Liberia. About 3,160 of those were confirmed, and we have over 4,800 deaths, including suspected deaths, probable, and confirmed. And the overall case fatality rate for the outbreak in Liberia was around 45%. So this graph actually shows the national picture of confirmed cases of EVD with the big wave, the first one, the one that happened in 2014. And it shows that by the time we were in August, there was this sharp increase in the number of confirmed cases, which peaked in October and then started to drop down until May the next year. This one shows the number of suspected cases that were reported over time from the 15th of April 2015 up until the 5th of May that same year. And the red dots here show that of all of these suspected cases of EVD that were being reported, because we obviously broadened the case definition for a suspected case because we were in an outbreak situation. So obviously we have more suspected cases being reported, but they were all being tested negative, hence the red dots you see at the bottom of the graph. So this is actually a flow of our routine surveillance information in Liberia. So the health system is broken down into different levels. We have the community level, where we have our community health workers, our community health assistants that have been trained in what we call triggers, community triggers related to the 14 conditions that are under active surveillance in Liberia. So they then report if they diagnose, or not diagnose, but if they identify or suspect any case or an event, they report that to the health facilities, which is the next and formal level. Now, a health facility has two individuals, at least two persons responsible for surveillance. So at the health facility, there are clinical standard case definitions for those conditions, and they will verify whatever alert that they get from the community. And if that alert meets the case definition for the condition for which is being reported, that information goes to the district. So at the district level, we have district surveillance officers who are charged also with the responsibility to verify whatever information coming from the community and subsequently report to the county. At the county, again, there's county surveillance officer, and then the Ministry of Health, where we have the Division of Disease Prevention and Control, and where the WHO IHR focal person sits. So during the outbreak, we thought to actually mimic what is here with our routine information, but just this time around, we were dealing with different data sources. So we had the lab that was responsible to give us lab results. We have the CCCs, which I explained about earlier, the community care centers, that were reporting suspected cases, suspected and probable cases of EVD at a point in time. Then we have the Dead Body Management Team, DBM for short. They were responsible to give us accounts on suspected deaths. They were responsible to give us information on how many persons died, because they were taking dead bodies from communities, also taking dead bodies from health facilities, ETUs, CCCs. So they were giving us on a daily basis information on how many bodies they were collecting from the different sources. And then there was the ETU, giving us information on how many cases they receive, how many cases survivors they've just discharged over a period of time, how many persons are still in care and treatment. And all those information came either in an Excel line list form or a tabular form in a Microsoft Word. And then that information was manually tabulated to come up with an aggregate daily situation report, which we call the daily SITREP, and also put into the District Health Information System 2, which is the DHIS2, our overall data management for health information system in Liberia. At the county level, they were also collecting similar information, but for their own operations and daily updates, they were developing their own daily SITREPs and having their own coordination meetings for operations. On the other side, the county people were doing case investigations, so there was a case investigation form and a contact tracing list. There was a form also for contact tracing, and these functions were given to the counties. So they will actually tabulate them. And then there was a version for DHIS2 at the county health team. People were trained on the use of DHIS2, and those information were manually entered into the overall DHIS2 for aggregate data analysis. So because there was an influx of partners, different NGOs, individuals, everybody wanted to do something, and during the onset, everything was just in disarray. We did not know where to start. We did not know where to place resources. We did not know how to solicit resources. So then the idea of establishing an incident management system, IMS, came about. So this diagram shows the coordination structure for the response at a point in time. So on the top, there was the Presidential Advisory Committee on Ebola that was set up purposely by the President of Liberia for the sole purpose of giving her a day-to-day report, whether progress, whether challenges, whether needs, a day-to-day report on everything that happens with the Ebola response efforts in the country. And then there was IMS, which was headed by the Assistant Minister for Preventive Care in Liberia at the Ministry of Health. And then there were three major pillars under IMS. There's our medical and planning. Medical and planning had 5 major thematic areas. That's how we termed it. And there was lab. There was episurveillance, which I was a part of at some point before I left for school. There was social mobilization, contact tracing, case management. And then under case management, we had the psychosocial committee and the day-by-day management committee. So for support, we had another pillar for IMS support, which actually covers logistics, operations, finance and procurement, monitoring, evaluation, and planning. And then there was the operation part where the counties were given the responsibility to run the day-to-day affairs of response within their counties from the standpoint of communities. And then we had national and international consultative groups that actually had the CDC, WHO, those international agencies to provide technical support and insight for response. Like I said, there was so many individuals and organizations involved, we could only keep tab, and if you look here, we have like 20, and this list is not even exhaustive. We just on top of my mind some of those that we could recognize at a point in time during the outbreak. This is a list of partners, specifically international partners, that were actually involved with the response efforts in the country. Now, Ebola came and hit a health system that was already struggling to survive. Our health system generally we were still building. It was generally weak, so to speak. I wouldn't bite my tongue on this part of it, because firsthand I know what was happening. There was firstly limited trained human resource for health. Our doctor to patient ratio is one of the lowest in Africa and even in the world. We have even midwife to patient ratio is also very low. We had very poor infection and prevention control system in country, and I actually personally did this for my master's thesis to actually look at transmission, risk factors to transmission amongst health workers in country because of this. This actually led to us losing around 7% to 8% of our trained health workers during the outbreak. We also had very limited lab capacity. That is something that even after the EVD outbreak, we are still working on. I did a lab assessment at the National Public Health Reference Lab, and the overall score using the WHO lab assessment tool was 45%. And when I presented that to the National Public Health Institute, there was some concern that I was even trying to be good in a sense, because they thought that obviously we still got a lot to do. And if with all of the efforts now, if that is true, then even before the outbreak there was something very, very big that we did not have. We did not have the equipment to do tests. CDC, WHO, they actually physically brought some of these equipment in. The PCR I'm talking about, to do ELISA tests and all that, they were actually brought in during the outbreak in order to speed up the turnaround time. We did not have those involved. We did not have trained people to even use them. At one point, we had the U.S. Army and CDC setting up mobile labs that were operated by Americans and other foreigners who, at a point in time, only because we wanted to speed up the turnaround time for results to be able to respond adequately. We have very poor referral system. Before the outbreak, I can tell you we did not even have up to 15 functional ambulances in country, nationwide. So that was actually very poor. In fact, even a system that looks at referral in itself wasn't very vibrant in a sense. Our surveillance and preparedness capacity was weak. We did not have that in place and running. For reporting on a daily basis, it was done through the cell phone. Someone from the Department of Disease Prevention and Control will, on a very beautiful day, just take his or her phone and call 15 persons in the county, and with the listing of those 14 conditions. Hello, how many cases of suspected cases of AFP do you have? 0. That person max 0. That's how reporting was done before the outbreak, and which we know in a standard sense that is not the best way to go. We also have very poor communication strategy at this point in time. When the outbreak struck, there wasn't a single message to communicate with the communities on how to prevent and control we had messages coming from the media, and because the Ministry of Health at the time did not have a more structured way of communicating, so there were different messages from all around the place, and one individual would just go on the internet, download anything about Ebola, paste it anywhere else for people to see. So there was no formal way of communicating, which led to some of the other challenges that may come up in the next. At the start of the outbreak, there was some serious issue with finances, and I can remember I was in the first ever meeting that we had, and there was this communique to our first branch of government, the legislature, to ask them to prevail upon the Ministry of Finance to make available around $2 million United States dollars for initial efforts to respond. And there was this senator who had so much influence, and he told us Ebola was a scam. He did not believe that Ebola exists. And in fact, the Ministry of Health and the Minister of Health and his cohort of people were trying to con them into eating money. So that was the initial understanding of what this was about. And because we did not have that at that point in time, in order to make some necessary adjustments for initial response, that led us to be actually open and more vulnerable for spread. So on the initial phase, there was this serious issue, and then there was this international rigmarole between the WHO and the MSF and other big organizations in understanding how they too could get their head around response efforts, which delayed the availability of the necessary funding for response. And then there was the political, which I touched on, and at the community level, some segment of the population felt that this was, again, another form of corruption, that the Ellen Johnson Sirleaf-led government was trying to create fear in their minds and trying to get money out of the system to enrich themselves, so they did not believe Ebola was real. And there was serious lack of adherence to messages for prevention and control, which one of the major ones was our burial rights. Okay, in Africa and in Liberia, there's this certain group of people who believe that if a person dies, that person should be washed. The body should be washed before burial. Yes. So, and after doing that, and those in charge of doing that are very close relatives. So they take the body, and that person is washed from head to toe, and the family members, if this person was great in a sense, maybe a religious leader or so, each family member will have to actually either wash his or her hands or her face with the remaining water that was used to bathe that body. This was actually a major issue for transmission, as we know that when a person dies from Ebola, the level of infectiousness is almost 4 times when he or she is alive. So, you know, the risks of being exposed to infection. So this was actually one of the issues that we were faced with, and there was a specific strategy crafted, and that was done in line with traditional leaders, that was done in line with religious leaders, to actually talk to people and make them to understand that in view of our traditions and customs, but there was something that existed at a point in time was actually real and was causing people to die, and we should try and understand that the Ministry of Health was in place to provide safe and safe and better burial for their relatives. So even this, after this was put in place, there was a serious issue with secret burials. So someone dies here, and if the community would not pick up that person that, okay, there is a death in this house, they wait until it's nightfall, around midnight, and then they go and bury. And then so when that started coming to our knowledge, then other apparatus of the government or the society started getting involved. We started getting the police, community vigilantes involved to keep watch on secret burials. These were some of the ways that we were able to put some of these under control. And then we had this resistance from the communities. I mean, they did not believe there was something called Ebola. And so a person who is maybe suspected of Ebola in this community will move to another community overnight. And that's how transmission was actually moving. Hence, the quarantining of West Point at some point in time. And then there was also movement of contacts. So you have a positive case in a household, but this contacts will actually move to a different place. So keeping in touch with them during contact tracing activity was actually a challenge for us. And then there was the lack of coordination, duplication of efforts and all that. But then there are some lessons we learned over time after this outbreak. We actually understood that the need to have an effective public health surveillance system that looks at timely detection or could not be overemphasized. We also learned that in all of the biomedical approaches in terms of treatment and all that, we shouldn't neglect human behavior and prevention. We also learned that it is important to have messages or message that speaks directly to your target population in terms of their social traditional context. And then we learned the need to have these basic PPEs available and to set up a very vibrant and strong infection prevention and control mechanism in the country, which we know that if these things are not put in place, tends to result in spread of infection. The way forward now in Liberia, we are building human capacity for surveillance. There have been up to 7 cohorts of frontline health workers being trained in field epidemiology using the CDC and Emory curriculum. We've revised our IDSR strategy. There has been 2 successive trainings since 2015. We've piloted one disease early warning system, which I was a part of. We did that in 4 counties and 75 health facilities. But at the end of it, after we evaluated, we thought it was too cost effective. Not cost effective, but it was too costly to run in a country like Liberia because it involved using Android phone and internet and all that. So we then came back to establish something we think will be more cost effective. And this is pending right now. I'm actually one of the coordinators for this project. The EIDSR initiative. We're supposed to start in 2 counties and around 77 health facilities. hopefully in the next month. We have developed some SOPs for IPC. We have these PPEs being pre-positions in encounters and health facilities. We have triage facilities in all of our health facilities now, which we did not have before. We have isolation facilities also in all of our health facilities that we did not have before. We have a preparedness plan, national one, and they've done several simulations over a period of time. There's a national risk reduction management strategy that has been put in place. So I actually thought to show you this initiative of the EIDSR that I talked about. This is just a diagram of how it's going to look like. There's primarily two major components of it. SMS bit that initiates from the health facility, and then there's what we call an offline tracker. The offline tracker is an app that was developed by a group called eHealth Africa. It's basically computer-based, desktop-based, so to speak. And then we're actually using the DHIS2, which is our overall overarching HIS platform. And basically, with the different levels that we have in our health system, an SMS is initiated from a health facility if one suspects a condition, and these red lines show where the notifications will go when a person sends an SMS. So there's a short code and then a short code for the disease, short code for the health facility that goes, the notification goes to the district health officer, the county health officer, district surveillance officer, county surveillance officer, and the National Public Health Institute, as well as the National Reference Lab, the county diagnostic officer, and Riders for Health. Riders for Health, after the outbreak, CDC contracted them. They're solely responsible for transportation of specimens from the point of collection to our laboratories. So, for example, if one suspects a case of measles and send that SMS alert, it goes to the lab so that the lab is aware that sample have been collected for that condition, so they get prepared to receive it. It goes to the county diagnostic officer who's charged with the responsibility of diagnosing diseases in the county, and then Riders for Health for pickup. And then that notification also goes to the DSO, the CSO for verification and to make sure that this conforms to the case definition. Now there's something they built, those techie guys, they call a sync server. It's actually a cloud-based server that syncs information or data from SMS to the offline tracker. Now this DSO will use whatever information from the SMS and the case alert form that is normally filled out when a case is suspected to populate and complete a line list for that case. And up here, there's another version of the offline tracker that is used by the lab, and the lab actually inputs only results for that condition, which is then synced in here and then up to the DHIS2 tracker. This DHIS2 tracker is like an extension of the DHIS2 that looks at specifically individual sub databases within DHIS2, and in this case it's for surveillance. People usually, at times, they can develop tracker for HIV treatment, they can develop tracker for maternal and child health. So those are just sub databases within the overall DHIS2. Now this information is up here and ready for use. I'm told Liberia will be one of the few countries that at the end of the day, if this works, will have some form of patient-based information for surveillance ready for data analysis and decision making. And so then I'm happy to be sitting up here and hopefully being able to look at some of these analytics as they come. What we want to do for our next step is to actually evaluate this EIDSR system, basically using the CDC framework for surveillance system evaluation that looks at assessing surveillance system attributes and ensuring that the surveillance system is meeting its objectives, and you can pretty much identify strengths and weaknesses and address them as we go along. Now, we want to take this one step further. So we know that the surveillance system as it is now, we're only looking at the human aspect of the health system. So we think we want to step it one step to have a One Health approach to surveillance in Liberia. And one of the reasons why I'm here in New Zealand today is because through Professor Hill and Professor Roger Morris, there was this project that started last year, October, that involved building a risk profile mapping system for transmission of infection from animals to human using a software called Handy2. So we're trying to see how in the very near future we can have a link between our human surveillance in one place as well as a risk mapping surveillance in another place, and having the two to talk to each other so as to have an enhanced surveillance within the country. With this, I want to recognize the University of Otago Department of Preventive and Social Medicine, Professor Hill and Dr. Crum. And I also want to recognize the Master University and Episoft International, Prof. Morris and his team, and the World Bank, who's actually paying for this project, and the Ministry of Health Liberia. And I want to thank you all for listening. Thank you for your patience. And I have some indication that I may have gone beyond the allocated time, but thank you so much for listening.
Thank you, Fulton. That was great. We've got like 1 minute for any questions. We do have a chief from Sierra Leone here if you want to talk to him afterwards.
Oh, wow. That'll be great.
That'll be nice. Ryan.
Is it true that WHO accepted responsibility for the size of the epidemic in the sense that the initial outbreak, they withdrew their resources, but it still wasn't the expected pay?
Yeah, I think I read that, and like one of the things I said, some of the reasons why there was very limited resources available during the start of the outbreak, we blame our government locally, and we also blame the international institutions like WHO, who so one way or the other responsible for provision of some of these support. So yes, I read a report that WHO took blame for the initial spread because they were not readily available.
Mr. Trump.
Thanks, that's great. So just a question about the electronic integrated disease surveillance and response system. I was just curious about the sensitivity of the system and your clinical case definition. So what sort of patients trigger a laboratory test for Ebola virus disease? Is it just fever and you're testing lots of people, or is it fever plus some more severe manifestations?
Yeah, so it's fever plus at least 3 of the other symptoms that I show in one of the slides. So you have fever, maybe vomiting, gastrointestinal symptoms to include nausea, vomiting, and all that. So it's fever plus at least 3 other that will actually, for lack of a better word, certify a person being a suspected case for EVD.
Great, I think we're being pushed out of here. So if you want to talk to Fulton, do feel free to come up and have a chat. Thank you very much.
I did not know this man. I went to find an explanation.